Sir, good to go.
Yeah, we can. So, good evening, friends. Dr. Rajamahendran here, your surgery faculty. Just this disclaimer. These are not direct repeat questions of NEET PG 2024, and just a discussion of the concepts asked in the exam we are going to have here. For those who are going to appear for the future exams, this will be helpful to know how the exam pattern has changed and how the questions are coming up. So let us. So this will give an idea of how the exam questions are being asked. So I request you all, please post your doubts and queries when the discussion is going on, or else whatever collection I'm having, I'm going to discuss with those questions. So let us start with some sessions. In the morning session, questions are here. Any doubts if you have, you can always post in the chat box. I'm watching the chat from another device. So to start up with surgery paper, surgery questions from NEET PG are really 100% standard questions. If you have read surgery with a full understanding of the concepts, these are the, I would like to first of all appreciate the examiner who has made these questions such a nice clinical oriented question paper, so which can be answered only if you have understood the concepts. You cannot answer based on any one-liner preparation or something like that. So these questions you can understand from the picture. Most of the questions had an image. So in surgery, most of the questions had image, and the choices and explanations are made based on the images. So therefore, you have to know about the disease, you have to know about the clinical features, you have to know about the images, then only you can answer most of the questions, okay? So let us start with the first question, non-contrast CT and CECT. So this is non-contrast CT and this is CECT. Contrast enhanced CT of the skull is given. So this is an excellent image. So you can see the subarachnoid space. What I'm now showing in the pointer is a subarachnoid space. Don't forget, this is subarachnoid space, what you're going to see here. This is subarachnoid space. So containing the CSF. So this is a subarachnoid space containing the CSF. It is usually black. Okay, it looks hypodense on a non-contrast CT. It will look hypodense. In a non-contrast CT, if you see here, it is looking hyperdense. So hyperdense subarachnoid space is due to subarachnoid hemorrhage. So this is a case of subarachnoid hemorrhage. Such an excellent question. It's a picture-based question from radiology come surgery. Subarachnoid hemorrhage image is given there. So I may not be giving the correct recall questions or the answers, but if you feel something is different, you can always post, but please try to learn the concepts. I'm not here to recall the NEET PG question paper or discuss about the NEET PG, but I want you to know the facts and how the questions are coming. This will be very helpful for those who are preparing for NEET PG 2025. You should know how the exam pattern has changed going more towards next exam. So this is a subarachnoid hemorrhage from the image. So there is an hyperdense lesion in the subarachnoid space. Otherwise, this will be black in color. You can see it is white in color. And what is the most common cause of subarachnoid hemorrhage? As most of you know, most common cause of subarachnoid hemorrhage in recent days is trauma. But olden days, what is answer? In olden days, it is used to be a berry aneurysm. Please don't forget, it's a berry aneurysm is the aneurysm arising from the circle of Willis. You can see in this picture, there is a aneurysm on a contrast enhanced CT scan. So on a contrast enhanced CT scan, you are seeing an aneurysm, berry aneurysm. So please remember, berry aneurysm, what is the treatment of choice? If it is not ruptured and it is still present there, you can treat it by clipping and coiling. By angio method, you can go for clipping and coiling is the treatment of this berry aneurysm. So this is a case of berry aneurysm, which is gone for rupture, producing a subarachnoid hemorrhage. So excellent question from first question. So can you find out what is the second question? from the image, they have given a classical image of the cells. You can see the cells are having appearance like this. Without a nuclei, what is this? Identify the genetic mutation leading to this following image. This is a papillary cancer. Papillary cancer is a case of showing you orphan. Good evening all, please, good evening all, welcome. We have started the session on time. So orphan nuclei. So this is a classical image showing you orphan nuclei. So with the empty nucleus. So they are asking in a papillary cancer, what is the mutations in? That is a question. So question is on papillary cancer causing what? What is the mutation in papillary cancer? So here I would like to tell you, there are three cancers usually seen. One is follicular cancer, medullary cancer, and papillary cancer, and follicular cancer. Sorry, anaplastic cancer. These are the four common cancers seen in the in case of thyroid. So in this, you all know very common MCQ. Medullary cancer is due to red oncogene mutation. So red oncogene mutation is nothing but MEN2A syndrome. Okay, MEN2A, MEN2B syndrome is red oncogene mutation. Anaplastic cancer is, this is very important. If you have a doubt, you can open and see Bailey and Lowe. All the questions are there in Bailey and Lowe. So the only person who can claim 100% strike rate is Bailey and Lowe. Nobody else can claim this question. This paper has 100% strike rate. If you have a doubt on any question, you just open Bailey and Lowe. That image, that question, everything is there in Bailey and Lowe. So I'm telling you, this time I want to appreciate the examiner for his genuineness. He has taken all the questions only from Bailey and Lowe, not from any other book. And all the images are mostly in Bailey and Lowe. And to be frank, he has made all the questions in a clinical oriented way so that only the students who have understood the concepts can answer. So you can understand it when you open Bailey and Lowe. So follicular cancer can have RAS mutation. Okay, RAS mutation. So papillary cancer, the choices, I want you to know the correct choices, whether they have given it or not. So papillary cancer is the one which is having some other mutation. You have to know follicular cancer, RAS mutation, medullary cancer, red oncogene, anaplastic cancer, P53 mutation. So papillary cancer, there is a new type of mutations like PTC1 gene was mentioned in New Bailey. I don't know whether they have that choice in that or not. So PTC1 gene is one mentioned in New Bailey for papillary cancer. So this question may be a pathology question also, because the image shows most common genetic mutation in a papillary cancer based on this image showing you orphan nuclei. So probably if I go with the Bailey and Lowe question, I can say PTC1 is the answer, but I don't see the choice from the recall from the students. So those who attended this question, please remember this is a question on papillary thyroid cancer mutation. So each cancer have a specific mutation. Follicular cancer has RAS mutation, medullary cancer has red mutation, anaplastic cancer of thyroid has P53 mutation, and papillary cancer is given in Bailey and Lowe as PTC1 gene mutation. Okay. So there will be no excuse if you are going to make a mistake on such type of questions like question number 3. Yeah, female with a breast cancer, they have not mentioned, but a lesion was mentioned. With the liver mets comes to you, what's the management? So many students are thinking this question as a Pillard's tumor. Please, first of all, understand the clinical concept. This is the point I want you to remember. Pillard's tumor will not produce liver mets. Please don't forget this basic point. Pillard's tumor will never produce liver mets. It is very, very, very rare to produce a liver mets. So if at all there is a question showing you, because I don't have the exact image, but if there is an image showing you a classical image of a lesion like this with a ulcer in the breast, can be a cancer breast. Cancer breast with such an extensive advanced T4 lesion can produce metastasis in the liver, very common. Such a case of T4 lesion with a metastasis in the liver, what do you think will be the treatment? So this breast is having a ulceration, necrosis. See, there is a necrosis of the skin. So therefore, I have to go for a toilet mastectomy for a, see, I don't know the exact question. I don't know the exact choices. But I will say you, if there is a cancer breast with a metastasis, which is M1 disease, already having liver mets means the survival is going to be 6 months to 1 year only. So my aim is now only palliation. So what all I can do as a palliation? palliatively, I can do number one, toilet mastectomy is important because otherwise the necrotic slough will have bad smell. BRAF V600CE, I will note it, but that choice is not there in Bailey and Lowe. If at all, it should be there in, it may be a pathology question again, I'm telling you. So BRAF 500, some students have written, as Hari has written, BRAF mutation, it is not mentioned in Bailey. I'm telling you again, this question is on papillary cancer, but I can exclude red oncogene, KRAS, both I can exclude. Some of the other two choices will be the answer for this question because I don't have the exact recall, but Bailey gives only one answer, that is PTC1 gene. So therefore, I will go for whatever the remaining choice is given, we have to go, but BRAF, I am not sure, which is not there in Bailey. So if it is not there in Bailey, I have no idea. So toilet mastectomy is done for palliative. So if it is a cancer breast having necrosis, first of all, we should go for second slot also I'm discussing. So don't worry, I'm discussing all the questions. This is not for question recall purpose. This is for students who are preparing for future exams. You go through these questions, how the questions came, you'll get an idea. So palliative toilet mastectomy is needed for necrotic cancer breast. And we have to give palliative chemotherapy will be given for those patients. So palliative hormone therapy also can be given if the estrogen receptor status is positive. So whatever it is, all these are palliative. There is no role of radiotherapy in this case. Why there is a role? There is no role of radiotherapy in a palliative patient. So there is no role of radiotherapy. Only we do simple mastectomy, give chemotherapy, hormone therapy until the patient is going to survive. So this is a very important point. So that is an excellent choice. I saw some of the choice from some students mentioning as neoadjuvant chemotherapy followed by surgery. So this is an accepted answer for the exam. So you can now, this is an advanced case. The only problem is, since there is a liver mets, I cannot go for this answer. Neoadjuvant is a word which is used only for locally advanced breast cancer. See, here I want you to understand this. A cancer breast is a favorite topic for the exams, you know very well. So I want you to explain what you do for a cancer breast. Okay, cancer breast is divided into only 3 types. Please understand the 3 types. This flowchart I have added in our regular class material also, in the app also you have this. Yearly breast cancer, which is nothing but T1, T2 cases. So T1, T2 and some cases of T3. And locally advanced breast cancer are all cases of T4 and some cases of T2. And metastatic cancer is M1. So this is actual 3 cancers. For an yearly breast cancer, the treatment what we usually do is, we can do breast conservative surgery or MRM, followed by adjuvant chemotherapy, hormone therapy, radiotherapy. This is for yearly breast cancer. Radiotherapy is not always needed. Some cases we do. It's a detailed discussion. And for locally advanced breast cancer, we do neoadjuvant chemotherapy, followed by MRM, followed by adjuvant chemotherapy, hormone therapy, radiotherapy. So this is for locally advanced breast cancer. Then what about metastatic cancer? This case is explaining a very clear concept on liver mets. When there is a liver mets, the survival is going to be less than 1 year. So that cases we will only do palliative. Don't do anything serious procedure. Palliative simple mastectomy can be done for an ulcerated cancer. Palliative simple mastectomy. Then we can go for what else? Palliative simple mastectomy, palliative hormone therapy, palliative chemotherapy. Radiotherapy is usually not needed for a metastatic cancer. So this is very important. Basic table. This is a table showing you the basic concepts. So please don't forget, this is a basic table showing you the concepts related to cancer breast management. Okay. So this question is based on a simple concept on how will you manage a cancer breast. A male comes to OPD with a perianal discharge for past 3. If you get any new choices, thank you, Mohammed Salman, for bringing that option. So that option we cannot use in this case because it is a case of metastasis. We'll go only for simple mastectomy for a palliation. Okay. So this is a fistula in ano. So the question choices, recalls, don't worry about anything. So those who appeared for the exam, just relax. Don't worry about anything. You can, in fact, you can relax through, and if you have time, you can go through this. This session I'm mainly doing for those students who are appearing for future exam. They should know how the questions are coming up in the exam. Okay. So this is an anus. So there is an opening shown in the anus. I'm not getting the exact image, but please remember, this is 12 o'clock position. This is 6 o'clock position. This is 3 o'clock. This is 9 o'clock. So if there is an opening, usually in any of these places, there is no confusion at all. Any of these patients. Only problem starts when the opening is given at 6 o'clock position. So 6 o'clock, if you see an opening in the image, it can be fistula or it can be pilonidal sinus also. So pilonidal sinus also. Both options can happen only in 6 o'clock position. Please remember, pilonidal sinus will not happen in any other position. Like in 12 o'clock, these places and all, you will never see pilonidal sinus. Pilonidal sinus means it will happen only in the gluteal cleft. If I draw the gluteal cleft, it will be like this. If I am drawing the gluteal cleft, this is a gluteal cleft and this is the anus. And this comes when you put in lithotomy, this is the 6 o'clock position. Usually, a pilonidal sinus will have an associated hair like this. There will be so much of hair with an opening, but not necessary always. But one clue I can give you is pilonidal sinus is very far away usually, not very close to anus. Pilonidal sinus will be very far away. But if it is a fistula in ano, it will be very nearby also. So this you can find out only in 6 o'clock position, you get a confusion like this. But if you have a picture showing you like this, in this picture, if you see, this is 12 o'clock, this is 6 o'clock, this is 9 o'clock. You will never get a 9 o'clock, you will never get pilonidal sinus. So 9 o'clock, you will get only a fistula in ano. Okay, therefore the answer is fistula in ano if it is in any other position. So I'm not sure with the question, but 12 o'clock position, 3 o'clock position, 6 o'clock position, all these, 9 o'clock position, all these you can go with fistula. 6 o'clock is the only place where you have a confusion. It can be fistula or pilonidal sinus, but pilonidal sinus have associated hair around the anus. Okay, don't forget this. A patient had adenocarcinoma of stomach for which he underwent gastrectomy. What should be the supplement for this patient? Simple question. So a patient underwent a case of adenocancer stomach for which he underwent gastrectomy. What should be the ideal supplement? So whenever we do subtotal or distal gastrectomy, the distal stomach being removed, so here is the place where intrinsic factor is secreted. So therefore, intrinsic factor deficiency results in B12 deficiency. So this is a simple repeat MCQ. There is no doubt it's a repeat MCQ many times asked in the exams. Okay, this is a repeat MCQ for your exams. So next question is again another repeat question. A woman brought her child to OPD with the complaints of recurrent vomiting. So interestingly, here they made a check for you because all of you used to prepare for PG entrance exams and you know what is the usual question. If it is a non-bilious vomiting, we go for congenital hypertrophic pyloric stenosis. If it is a bilious vomiting, we go for duodenal atresia. So it was not mentioned in this. And if it is a mention of X-ray, we will easily answer showing a single bubble, seeing a double bubble, but they didn't give an X-ray. They give an ultrasound. Please remember one point. Ultrasound is used only for congenital. Congenital is now known as idiopathic hypertrophic pyloric stenosis. So you don't know about the image also. If there is a point mentioning ultrasound for a small child, it is only a idiopathic hypertrophic pyloric stenosis. And the image shows thickened pylorus. Okay, this is an image of thickened pylorus and thickened more than 4 mm, lengthened more than 16 mm. This is a classical image showing you idiopathic hypertrophic pyloric stenosis. Okay, so please don't forget any doubt if you have. It is given 3 o'clock means it is classically Hari. Thank you, Hari. It is if it is in 3 o'clock, it is mostly a fistula, not a pilonidal sinus. Pilonidal sinus will happen only in places of abrasions. Okay. So the answer for this question is hypertrophic pyloric stenosis, showing you a narrowed pylorus. This is a narrowed pylorus. So here is a question I could not get a proper recall. Cystic lesions in the ventricles in radiological investigation, patient died and gross picture and histopathological examination image. I could not get this image. But one thing I can tell you, most common brain tumor is astrocytoma. Okay, but astrocytoma is not cystic. It's not cystic. It is a solid tumor only. Astrocytoma is not cystic. It is solid tumor. So if there is a cystic lesion, the cystic lesion, one option is neurocystic sarcosis. It can be a neurocystic sarcosis, but I could not get the classical picture and the image. So if any of you could recall this question, you post it so that we will discuss in the regular discussion type. But Astrocytoma is not cystic. It is solid in consistency. That is what I'm telling you, it's a classical solid lesion. It will grow from one lobe of the brain to opposite side. Therefore, it is also called as butterfly tumor. It is an aggressive tumor. Butterfly tumor is the name of astrocytoma. It's an aggressive tumor. Therefore, you should know about this. So, 9th question, after RTA, so I think this lung biopsy immunohistochemistry is positive for TTF1. I don't think this is a surgery question. I think it's a pathology question. So you will be seeing this question in pathology. Leave this. After RTA, patient was admitted. There is an adult worm in the gross image. Okay, there is an adult worm means no doubt it is a classical. So morning paper is very straightforward paper. There is no confusion or no controversy. So after RTA, patient was admitted, chest X-ray was shown below. So this is again a multiple times repeated question. There is multiple ribs fractured, more than 3 ribs fractured in more than 2 places. It's called as flail chest. So all of you know what will happen in a flail chest. Flail chest will have a paradoxical respiration. Okay, flail chest will have a paradoxical respiration. So thank you, Tirupati. Thank you. See, this is a flail chest having a paradoxical respiration. Okay, that is paradoxical respiration is on inspiration, that segment will go on inspiration, it will go inside, it will move inside, and on expiration, it moves outside. It moves outside. So don't forget, this is a simple repeat question. No, I don't think any controversy in this. So if you have any doubt, please tell me. So flail chest is fracture of 3 ribs in 2 or more places. So what is difficult in this image? I could not get what is this image, whether it's an anesthesia question or not. So I could only note from the picture given, I could only see it's a narrowing of the trachea, narrowed trachea I could see, and also deviated trachea I could see. So from the picture of narrow trachea or deviated trachea, the anesthesia question maybe it will be difficult to do tracheostomy or a intubation. Okay, nasotracheal intubation may be difficult. So I don't know the exact choices. If some of you could recall the exact choice of this question, it will be useful for me. So anybody could recall the question on this X-ray? What is difficult in the given image? Can you tell me what is this image? If some of you could know the image or recall the image, please tell me, because this is since the over students are in immediate exam mode, so I don't want to disturb them asking for complete recall. If any of you have appeared for the exam, please post. We will discuss this question. So following is an image of burns patient. What is the next line of management? So this is a picture showing you well granulated raw area. So raw area. So when there is a raw area, please remember, so tracheal deviation is there means, yes, it may be difficult to do a tracheostomy. Yes, tracheostomy is the ideal answer for that question. Thank you, Mohammed. So this is a raw area. Okay, this is a raw area shown here. In this raw area, you can see granulation is very well. Granulation present means bed is good. Granulation tissue is grown means the blood supply is good. When blood supply is good, what will I do? When blood supply is good in a raw area, I will go for split skin grafting. Okay, split skin grafting. If blood supply is not good, blood supply is inadequate due to exposed bone or other things, I will go for a flaps. So this is a well granulated tissue. I will go for split skin graft. That will be the correct answer. So full thickness graft will be only done for smaller areas. I cannot do it for larger areas. Only for smaller areas, I can do a full thickness graft. Vacuum dressing will be done only when the wound is infected. Infected wound we can do, but this is a burns case with a well granulated tissue. So it is not needed. That's why I'm telling Hari, that may be a anesthesia question. That the tracheal deviation question is not surgery question, maybe an anesthesia question. So I will forward it to anesthesia faculty, let him discuss. So this is a classical. We had around 25 questions in the morning session, around 20 questions in the afternoon session. From the recollection I heard from the students. So this is a vacuum assisted closure device is not needed. It is a classical split skin graft is enough. So this is again a repeat question. This is a multiple times repeat question. Grade 4 bed sore will have exposed bone. Exposed bone is seen in grade 4 bed sore. This is a case where we might need vacuum assisted closure device followed by flap operation. So followed by flap, because there is an exposed bone, so it will not form a granulation tissue. So we have to do a vacuum assisted device and then close it with a flap. See, all clinical concepts. There is nothing difficult to remember, and it doesn't mean this paper from the first paper you can understand. It doesn't mean you would have prepared and you would have revised also. Once you have understood the concept, even before 6 months, you can answer this question. So if you have not even read in the last 1 month surgery, you would have answered all these surgery questions. If you are very strong with the concepts, there are no fact-based questions like what is this, what is the sign, what is the value, what is the scoring system. Nothing is asked. They are purely clinical questions. So this is a grade 4 bed sore because bone is exposed. In a grade 1, only erythema. Grade 2, partial thickness loss. Grade 3, full thickness lost, but subcutaneous fat alone seen. Subcutaneous fat is seen. Whereas 4, it is bone seen. Okay, that is a classical bed sore. It is again another, I don't know, many students made a mistake in this. This is a classical protocol for cancer penis. Following is the finding you see. Following lesion was found and it is stage 3 in a cancer penis. This is a cancer penis. No palpable lymph nodes are clinically found. What is the management? What is the management for a no palpable nodes? See, this is again a protocol. So the cancer related question, they have very clearly asked the protocols. So let me explain you what we do for a cancer penis. These are simple flowcharts we have added in our material as well as in our classes. Simple question. If you understand the concept, no need to revise at all. This is not a tough question. Please understand. There is a cancer in this part of the penis. Any cancer in the penis, we have to give a 2 centimeter margin and cut it. Either a partial penectomy or total amputation. Total. Something you have to do. So if I don't have a residual stump of 2 centimeter not available, I will go for total. Otherwise, I will go for partial. So whatever it is, first of all, we should do penectomy. According to the clearance oncology principle, we have to do penectomy. So after doing penectomy, so don't worry about the nodes, etc. now. Just don't worry about the nodes. First to do penectomy. That is the concept. So do penectomy. 15 days. Give antibiotics. First step in a cancer penis is to do a penectomy because it's an ulcerated growth. There will be so much of wound infection. Therefore, wait for 15 days and now palpate the inguinal region. Previously, palpable nodes may now become, if it is an inflammatory node, they will become absent. So 15 days of antibiotics. If nodes are absent, what will you do? 15 days of antibiotic. If nodes are positive, what will I do? Very simple question. If nodes are positive, you want to confirm, you can now do an FNAC and confirm it is positive. And you can go for a ilioinguinal block dissection. This is a surgery done for inguinal nodes. Ilioinguinal block dissection. So this is a simple, straightforward concept. If nodes are negative, what will I do? So we will not send the patient if nodes are negative. See, cancer penis, T3 stage, there may be nodes. So olden days, they were doing a simple procedure known as sentinel node biopsy of Cabana. It is no more. This concept is gone. Now, recent concept is what? Do a superficial inguinal nodal dissection. Superficial inguinal nodal dissection, or you have to do a modified dissection of Catalona. Catalona is also a type of small type of dissection, and you send these nodes for frozen section. If they are positive, you should do a complete ilioinguinal block dissection. This is the concept from super specialty books. For Bailey and Love, simple. Sentinel node biopsy. Node negative means go for superficial inguinal node dissection. Node positive means ilioinguinal block dissection. This is what Bailey says in simple word. But there is a deep concept behind this. It is not needed for you. For PG level, PG preparation level, partial or total penectomy with a 2 centimeter margin with the nodal clearance for node positive cases. And we have to do, instead of sentinel node biopsy, superficial ilioinguinal block dissection is the answer for this question. So penectomy with the superficial inguinal node block dissection. Actually, the superficial inguinal node block dissection is now renamed as modified dissection of Catalona, but it is not there in Bailey. Therefore, you can go with the superficial dissection. Okay. So, yes, Hari, that's correct. Well granulated tissue, whatever large area, we can go for a graft. So Fillard's tumor very rarely metastasizes, and Fillard's tumor with the metastasis patients also have poor survival. Even for them, there is no role of neoadjuvant chemotherapy. So the answer, first of all, you have to answer for that is Ulcerated breast cancer is usually produces metastasis. The question examiner, that is all depends upon the image. So probably it is a cancer breast with an ulceration. That is what I feel. I don't think large tumor, if they want to tell, they won't bring metastasis at all. Okay. Liver metastasis, we have never seen a case of large tumor. So fistula, this is an applied anatomy question, though not a pure surgery question, between long saphenous vein and 3 centimeter behind medial malleolus. No doubt it is posterior tibial artery. So a fistula created between saphenous vein and what is seen behind you used to palpate. No, we used to palpate posterior tibial artery 3 centimeter behind medial malleolus. So they are simply asking a question: where will you palpate? What will you palpate 3 centimeter behind medial malleolus? Answer is very simple: posterior tibial artery. So after an amputation, after a road traffic accident, this is also an applied anatomy question. A lower limb amputation was done. See, anatomy, physiology, biochemistry, all the questions are only applied questions. There is no straightforward, typical anatomy question you can see in this exam. Mostly they are applied anatomy questions, which are mostly answerable in surgery or in medicine or in other subjects. So this is a road traffic accident, lower limb amputation was done. So this is a knee, and usually we have to give a stump with this. So this is a stump of around 8 to 10 centimeter stump is needed for putting a prosthesis. And when we are closing it, we use a posterior flap and we close it. Posterior flap will be used to close. And now they are taking an image, cut section image at this level. At this level, they have taken an image. So at this level, we have 2 bones. So what is this amputation? You can see tibia and fibula, and you can see the compartmental muscles, etc. So this is probably a below knee amputation. It is not Lisfranc or Chopard. Lisfranc, Chopard and all will show you multiple bones. They will go very lower. So these are not classical of amputation, but I expect you this to read from either from orthopedics, a lower limb amputation related concept. For a patient with a left cheek cancer, tumor excision was done and constructed with a flap. Modified neck dissection was done. In which condition adjuvant radiotherapy is done? See, this is a classical question again. Again, a concept on oral cancer. See, I always used to tell, when it is a surgery paper, 50% will be onco surgery questions. So onco surgery related concepts. So I don't know, I'm not sure with which session and all, because I could collect from sources, various sources. I'm discussing overall the concepts asked in the question. Okay. So this is a oral cancer. Oral cancer, if you see, we have to give a wide local excision. After wide local excision, similar to cancer penis, we have to do modified radical neck node dissection for node positive patients. So modified radical neck node dissection, after doing a neck node dissection, like removal of level 1 to 5 nodes, and all the other structures like sternocleidomastoid, internal jugular vein, spinal axillary, now these are preserved in MRM. In radical, modified radical neck dissection, we preserve them. So when I'm doing this surgery, when will I give post-op RT also? Usually when you do surgery, no need of RT. No, when will I do RT? When there is an extra nodal spread, extra capsular spread. This is a classical MCQ. If this is a biopsy, this is a node. In the node, if there is an extra capsular spread seen, means it can cause local recurrence. So only when there is an extra nodal spread seen, I have to go for a extra nodal spread. We have to go for adjuvant radiotherapy. So a patient with myasthenia gravis comes to OPD with a distended jugular vein. CT thorax was done. So it's a classical image, directly a concept from Bailey and Love called as Thymoma. Thymoma Masoka staging is used. It is a type of tumor. These patients produces paraneoplastic syndrome plus outlet obstruction or superior vena cava obstruction. Paraneoplastic syndrome plus SVC syndrome. One of the most important paraneoplastic syndrome is myasthenia gravis. See, so many clues they have given. Myasthenia gravis patient is given. Distended jugular vein clue is given. CT is given with the thymoma image. Even if you don't know to read the CT scan, you would have answered seeing the myasthenia gravis and distended jugular vein. So such a conceptual question. So we have never seen this type of conceptual questions in so many exams. They have given clue for the questions and answers also. This is from first session. I actually got the first session questions discussion going on. So a patient with the hoarseness of voice CT angiogram was done and the following image is obtained. What is the cause? So hoarseness of voice with the CT angiogram, I could not get the image, but hoarseness of voice can happen from aneurysms. Okay, any type of aneurysms can cause hoarseness of voice. If at all I could get the image, I can answer this question. But please remember, this is a question. Anybody could answer this question. Patient came with the hoarseness of voice. CT angiogram was done. Following images obtained because mass in the mediastinum, a mass in the mediastinum causing hoarseness. So mass in the mediastinum causing hoarseness, most commonly it is esophageal malignancy. It is usually a esophageal malignancy, or it can be due to some aortic pathology. Aortic pathology like an aneurysm, like a saccular type of aneurysm. Okay, not like a dissecting aneurysm. Mostly it's a arch of aorta aneurysm. So if at all this question, if somebody could recall, it is usually a sac of aneurysm. Yes, thank you, Hari. Thank you so much. Hope you all have done it very good. So distal arch of aortic aneurysm. What is shown in the following image? See, I have added 250 concepts so far in my Instagram channel. I don't know how many of you are seeing my Instagram channel, Surgery Sixer. I am just posting the images and videos of what I'm seeing in my day-to-day practice. I have posted this image already. I have posted around 20 questions of images have been asked in the exam. So thank you, Dr. Santosh. I think it is a saccular aneurysm only will be the correct answer, because as it is bulging, it can dissect the nerve and it can cause damage of the nerve. So saccular aneurysm will be a better answer. So this is a picture showing you a classical image of esophageal varices. I have discussed this question in my Telegram Surgery Sixer. Even up to the management, I have discussed what should I do. So treatment of choice for this type of varices is endoscopic banding. Endoscopic banding is a classical answer for this question. So endoscopic banding will be needed for these type of cases. Okay, so noted, Hari. We will update in accordingly. So this is again a question directly. If you have a doubt, you can open Bailey and Love. This image is directly in Bailey and Love. Water lily sign. You can see the classical water lily sign. So this is based on a classification CE1, CE2, CE3, CE4, CE5. This is a classification. CE1 classification of Hydatid cyst is a clear cyst like this. It's a clear, simple cyst like this, clear cyst. CE2 is a water lily cyst. Sorry, CE2 is honeycomb cyst. CE2 is honeycomb like this. CE3 is water lily appearance or water snake. CE4 is heterodense. It is mixed of liquid and solid components. 5 is calcified. This is CE classification. Okay, of they have asked CE or Garby classification. Garby classification is actually outdated. Garby classification is no more given in Bailey and Love. In fact, I don't know the Garby classification now. So what is now followed is WHO classification. It is actually given in Bailey. They have asked Garby classification particularly. So I don't think there will be something from Garby classification, because Bailey I'm having in my hand, because this is a very classical question from page number. There is a question with explanation. Everything is there in Bailey and Love Hydatid cyst chapter. You can open page number 74 in Bailey and Love. Classification of hepatic Hydatid cyst. This is what given. CE3 is detached membrane and CE4 is mixed hypo and hyperechoiculation, like that. This is the only classification given in this book, because Garby classification has been outdated long back. So this is known as WHO IWG classification. This is the latest classification from Bailey and Love. IWGE classification, International Working Group classification, from page number 74. This discussion I was able to make so easily because this is most of the questions are from Bailey and Love. Most of the questions are from Bailey and Love. Since it is not mentioned in this book as Garby classification, I'm not sure with the Garby classification, because it is a classification which is removed 5 editions back itself. What we have now is WHO classification. This is the classification of WHO. Anyhow, I will verify whether there is any other source giving about Garby classification. This is actually CE classification of Hydatid cyst. We commonly do this discussion, and CE No, even won't examiners, see, this is one point I want to tell you. So examiners cannot take questions just like that from some question bank or from somewhere from their own practical knowledge. Always they are supposed to take questions only from the standard books, either from Bailey and Love or from Sabiston. They may not be a old examiner who can ask just like that sitting from somewhere and make a question by his own. Because I know my professor used to take questions when I was in MMC. I was asked by him to give some questions with the reference. He used to get questions from me and some other PGs also. So we used to write questions and give him. So he will select some questions and send it to university during the exam. At that time, the specific notes from the examiner will be, it should be only taken from the standard books for the exam. So they can never ask any question out of Bailey and Love. If there are some questions out of Bailey and Love, it is not surgery question. That's all I can say. If it is not there in Bailey, it cannot be a surgery question. So surgery questions are taken only from Bailey and Love. So Garby classification is outdated classification. Probably examiner would have named it as Garby and the actual name is WHO only. This question answer is CE3. But let me verify Garby classification from other books. So Arnikas, this is the time you should start NEET PG preparation. As a final year student, there is no difference between NEET PG preparation and final year preparation. Just see the quality of the questions asked in the exam. This is the way you have to prepare for your final year also. Okay. So patient with a reducible mass in the umbilical region previously now comes with the pain and irreducible swelling. This is a case of umbilical hernia. So reducible now becomes irreducible, means umbilical hernia obstructed. I heard so many questions came from the umbilicus, and there are so many memes also created from umbilicus related pictures. So many questions from umbilicus. So many, the examiner is umbilical fetish, like that. So many memes are being circulated. The umbilicus is one of the important organs for any surgeon. Just now, today morning, I completed on umbilical hernia. So this is one of the important area. If a practicing surgeon wants to ask so many questions, he will ask questions from which he is practicing more. So he might be a general surgeon who is operating more on umbilical hernia or umbilical pathology. Let us discuss all the umbilical pathologies in one go in surgery. Umbilical pathologies. Don't forget umbilical pathologies. So common pathology we see in practice is an umbilical hernia. So umbilical hernia. That is very common. You can easily identify from the cough impulse, reducible, or it can become irreducible. So other important pathology we see in our practice is umbilical granuloma. Umbilical granuloma is easy to treat just with the silver nitrate cautery. Silver nitrate. I can cauterize that. It will bleed on touch. So umbilical granuloma will have bleeding on touch. So it bleeds on touch. So I can easily treat it by a silver nitrate. Now comes the most important umbilical problems in which the umbilicus and structures below the umbilicus are not developed. Umbilicus and structures below the umbilicus are not at all developed. It is open like this. So it is exposing the posterior wall of bladder. That is extropia of bladder. Extropia of bladder. This is a congenital anomaly. So whatever I am putting C are all congenital anomalies. Extropia of bladder. So another important pathology which is seen at the umbilicus level, there is a herniation of membrane with umbilicus attached to the summit. What is this? Bowel and all seen below the membrane. This is omphalocele. Omphalocele. And what is other umbilical pathologies? There is a patient coming to you with an umbilicus opening with the motion coming out of the umbilicus. Motion coming out. It is a connection of the umbilicus with the terminal ileum. That is nothing but vitellointestinal duct persistence. It is motion coming via the umbilicus. If a patient comes to you with a raspberry tumor of umbilicus, a tumor-like appearance in the umbilicus, it is called as raspberry tumor, also called as umbilical adenoma. It is nothing but distal vitellointestinal duct persistence. Distal vitellointestinal duct persistence. If urine coming out of the umbilicus, what is it? Urine coming out of the umbilicus is persistent allantois. Persistence of allantoic duct, also called as urachus. So these are that's all umbilical, all problems are solved. So amnion covers omphalocele. Yes, these are the umbilical pathologies seen. There are so many questions from umbilicus I heard. So that's all. Maximum umbilicus discussion is only half an hour. Simple concept, don't forget. So for an umbilical hernia, what will I do? I will do not umbilicectomy. We don't remove the umbilicus. No need. So we can do Mayo's repair. If given the choice, Mayo's repair I will do, or I will do a simple procedure like mesh repair. No need to remove the umbilicus. It is not mandatory to remove. Okay, it is not mandatory to remove. In umbilical hernia, we don't need to remove umbilicus. Okay, it is not needed. So this is a cleft palate, simple question. Cleft lip plus palate. A patient coming to you with a cleft lip will be operated by 6 weeks. A baby having a cleft palate will be operated by 8 months, 18 months. So when should you repair the following condition? This baby is having cleft lip and palate. See, in cleft palate, hard palate is repaired at 18 months. But soft palate should be repaired by 6 weeks. Why 6 weeks? Can you tell me? The answer for this question, I don't know. Many of you have not understood the concept. So cleft lip plus soft palate should be done. First stage operation should be done at 6 weeks. Then only the baby can go for feeding. Otherwise, there will be problem in feeding. They can aspirate, they will go into nasal, regurgitation will happen. Therefore, for a cleft lip to keep the mouth and suck the breast milk, the baby needs closure of this lip. Otherwise, the baby cannot suck the milk. Therefore, by 6 weeks, I should operate cleft lip. Only if there is a question mentioning about hard palate, we operate by 18 months. Don't forget. But in this image, I cannot say, I can say classically there is a cleft lip, so I will go for 6 weeks again. Just 3 months. So many options are there, but what is done for these patients should be by 6 to 10 weeks, we have to operate for cleft lip. For lip, you have to operate because otherwise baby cannot drink the milk properly. Please understand this basic. Again, this is a concept-oriented question. So this question just now I discussed. You can see the exposed bladder called as extropy of bladder. Extropy of bladder. Extropy of bladder. So when the abdominal wall is absent, it is called as extropy of bladder. We cannot delay the cleft lip alone. We can delay other surgeries. Cleft lip and soft palate should be operated at the earliest possible. Okay, as the earliest we have to possible, we have to operate the cleft lip alone. For lip alone, that is a concept. So this is a little controversial question because it depends purely on the examiner's clinical situation, what they are asking, what image was given in the exam. So let me tell you, this is a classical pediatric surgery question. You should not have a doubt in this pediatric question. Because cleft lip, cleft palate has been a favorite question of the examiners. Every old papers, if you open, there will be a question on this. So the time of surgery is very common. 18 months is correct only for hard palate because we need that much of time for the bone to develop. So that is needed for 8 months. So I would like to show you the table from Bailey and Lau on cleft lip and cleft palate. See, I'm telling you, any question, if you have a doubt, if you have Bailey and Lau soft copy or hard copy, just open and see the question. Don't even trust the discussion by the faculties. I'm telling you, don't even trust me. If you have a doubt, you just open the Bailey and Lau. If there is a controversy, just open Bailey and Lau. The answer will be definitely there. No doubt you will have that answer. I'll find out what is the answer for cleft lip and palate. But please don't forget, cleft lip should be corrected as early as possible from the practical point of view. So from practical aspect, you should never have a doubt. Cleft lip should be operated as early as possible. So even if you have a doubt, you can open from your pediatrics book. That faculty also might have discussed cleft lip and cleft palate because it's a pediatric question. So let me show you from cleft related questions. Ideal time of surgery is very classically given in Bailey and Lau. Should not have any doubt in this ideal time of surgery. When will you operate a cleft lip? So there was one table from Bailey and Lau. This is explained in page number 740. You can go open and see page number 740. Page number 740, they have explained about the various time of surgery for cleft lip and cleft palate. Don't have any doubt. If you read that, in fact, if you read this choice concept in Bailey, you will immediately recall the question perfectly. You will recall the perfect question without having any doubt. So this is a case of TB, sterile pyuria. So when a patient, these are multiple clues are there in this question. When there is a TB, the patients will have sterile pyuria. Sterile pyuria means there is only WBC seen, but no bacteria seen. That is called as sterile pyuria. There is presence of WBC, but no bacteria seen. That is a classical sterile pyuria. So in a chronic TB, what are the findings? That is what you have already read. This is a very common concept. Chronic TB, there will be Golf hole ureter. There will be thimble bladder. Thimble bladder is a small contracted bladder. Golf hole is a very small narrowed ureter. It's a narrowed ureter. See on a patient, what is the diagnosis on a cystoscope? I am putting a camera and I am seeing there is a golf hole ureter. So answer for this question is golf hole ureter. I hope you will understand this question. So bladder, thimble bladder is a small bladder which I cannot find out with only with a cystoscopy. To find out thimble bladder, I need cystography. Cystography is needed for thimble bladder. Golf hole ureter, I can say it's a narrowed ureteric. I don't know other choices. Yes, there is another choice of baby passing fecal material on and off means definitely it is a case of Meckel's persistent vitellointestinal duct. Meckel's diverticulum, when it is persistent full length, it is called as persistent vitellointestinal duct. It will cause motion coming out. So yes, golf hole ureter is there in the choice. Without doubt, you can go with that question. See, urology questions are very commonly asked, but urology questions are very basic questions. This is also discussed in our Surgery Sixer Instagram channel. I have posted this. This is a double J stent. Double J stent, which is inserted and taken out with the help of cystoscope, cysto-ureteroscope. So no doubt at all. You can see a classical thing which is done with the help of cysto-ureteroscope. Okay, cystoscope is enough. Actually, there is an answer. Cystoscope alone, that is also enough. But cysto-ureteroscope, it is better answer if it is given in the choice. Okay. During cystoscope insertion, the scope moves freely, but micturating cystogram is showing this picture. This is a very classical clinical question. Multiple times we have discussed in our class also. See, this is a urethra. This is bladder. In the case of membranous urethra, this is a valve which is seen in membranous urethra. This is a valve like this. When I am passing a cystoscope from below, the valve will open because of the pressure. But when the patient wants to pass urine, this valve will close. It will be like a flap valve. It will open when I go from below, but it will close when I'm passing urine. This is a classical image showing you micturating cystourethrogram, showing you what is this. This is a posterior urethral valve. Don't forget, this is a posterior urethral valve. So posterior urethral valve can be easily treated by cystoscopic resection. Cystoscopic resection is enough. By means of laser, nowadays we are resecting. Removal of that stricture is not correct answer. If it is a stricture, we will do dilatation, but if this history is there, it is not stricture. During cystoscope insertion, if the scope moves freely means what? It is not a stricture. Please remember this, it's not a stricture. It is something like, but micturating cystourethrogram is showing a narrowing there. That means what? It is posterior urethral valve. What? See, this question you can understand, they don't give a diagnosis, they want you to make the diagnosis and then come to the treatment. So from the image, they have given, this exam had an interesting point. I don't know how many of you could understand it. They have given a clinical situation, clinical scenario, which you can answer the question without seeing the images also. So clinical scenario with image. So many times you can answer with only the clinical scenario without even seeing the image. So I can answer this question without seeing the image. That is the scope moves freely, but micturating ureterogram shown below means MCU is done only for posterior urethral valve. That is showing a valve obstruction here. We have to cut that valve with the laser. Okay, that is has to be cut with the laser. Oh, bladder diverticulosis is not the correct answer. Okay, if there is a choice of bladder diverticulosis, that is wrong. Okay, fecal soiling around the umbilicus is patent vitellointestinal duct. No doubt in that. A child with a recurrent bowel obstruction on laparotomy was observed. I think this question I could not get the proper choices. On laparotomy, the baby was having a what finding? Recurrent bowel obstruction. That is seen in Meckel's going for intersusception. Meckel's going for intersusception may be one of the reasons for recurrent bowel obstruction. That is one of the important answers. The small baby having a Meckel's, this Meckel's will invaginate and go for intermittent obstruction and pain. That is one important point you should not forget. So vacuum assisted closure drain pressure is minus 120 millimeters mercury. We have discussed this multiple times. So minus 120 millimeters mercury. Endoscopic ablation, excellent choice. That will be the correct answer. Hari, I was waiting for that choice because I could not get the choice. Endoscopic ablation is the correct answer of this question. Okay, that is no doubt. That is the correct answer. You can have classical answer. So SST derives nutrition after 72 hours. See, I think this is an afternoon question, not morning question. Morning they asked a simple question. See, every year we have seen there are two papers means morning paper will have a easy question. Usually this is what happens. Because the same examiner only taking question. No, he will take two questions. Morning, he will put one question, one paper, this question, one paper, another question. Afternoon session, he will ask a question deeper into the same concept. Morning, a concept is asked superficially. The same question concept will be asked in deeper in the afternoon session. This is what happens usually. It has happened previously also. So don't think all morning people, those who had an easy paper, you will be getting a top rank. And all those who attended afternoon paper with a difficult question, don't think you'll go back. You'll get much better rank than you expect. So morning people, those who thought it is an easy paper and you are very happy, you might go behind what you expect. Afternoon people who wrote it so difficult and you are feeling so much depressed, you will come up. You will be more better rank than an easy paper. This is very commonly happens. You will tell this after the exam. You'll know this. And what I'm telling now, you will know and you will tell after the result of the exam. So morning paper will be easy only, but the same concept will be asked in the afternoon paper. See, this concept, what is asked in the morning paper, they asked about split skin graft image, simple concept. But afternoon paper, what they're asking, when I'm putting a split skin graft on a raw area, how it will survive? First 48 hours, it survives by plasma imbibition. This is a direct repeat question from Bailey and Love. From 48 hours to 5 days also, there will be inosculation. What is this inosculation? Please don't forget, this is a raw area and this is the graft I have kept. In the first 48 hours, it derives the nutrition from the plasma coming, no? So with that, the graft survives. But after 48 hours, there will be new vessels formed from above to below like this. Those vessels will align. That is called as inosculation. And after 5 days, revascularization happens. And the graft gets its blood supply from the recipient area. This is the same question, same concept asked in a tougher way. So, split skin graft, see, you have got a question from a split skin graft now. So it is by inosculation. Okay, imbibition for first 48 hours. On 72 hours, it is by inosculation. See, double J stent inserted by using cystoscope. Identify the MRM image. Long thoracic nerve was identified in the image. This video I have put. So what are the nerves which you will be encountering during an MRM means? Please remember the boundaries of axillary dissection. Axillary vein. This is the medial most boundary running on the chest wall. When you get an image of a nerve running on the chest wall, it is Bell's nerve. When you see a nerve running along with an artery, vein, and you are seeing a nerve running like this here, this nerve is called as thoracodorsal nerve. Okay, thoracodorsal nerve. And these are small nerves which are going like this. Small cutaneous nerves known as intercostobrachial nerve. So they can ask as images only these three questions. One, they can ask a Bell's nerve, or they can ask a thoracodorsal nerve, or they can ask a small nerves traveling like this called as intercostobrachial nerve. So only three of this can come for your exam. Okay, this is a case of Bell's nerve. From the image, I think this is a Bell's nerve image. On TPN with a metabolic syndrome to surgery ICU patient, what will be happening? So this is a simple question. When a patient is on sepsis, on TPN, this is a repeat MCQ we have discussed very classically in our classes. Patient who is having sepsis, and sepsis is nothing but metabolic syndrome. Patient is having a metabolic syndrome, maybe a metabolic alkalosis acidosis, something is having a metabolic syndrome. The first important reflection is on blood sugar. Immediately you can see here, blood sugar elevated. That is the first sign of sepsis. First sign of sepsis on a patient with TPN is elevated blood sugar. Don't forget this point. So there is no confusion. There should be nothing else. Hyperlipidemia, hypertriglyceridemia, hypoglycemia, everything is wrong. In a metabolic syndrome patient, hyperglycemia is the first sign. Okay. See the next question. Most common site of congenital diaphragmatic hernia in a neonate. So in the afternoon paper, little complicated paper. I can accept it's a little complicated paper, but unless you have understood the concepts, it will be little difficult. So this is the congenital diaphragmatic hernia. This is one defect called as Bogdalak defect, Bogdalak hernia. Through this Bogdalak hernia happens, it is left posterolateral. So this is the most common type of congenital hernia. Very rare hernia happens medially, anteromedially, called as Morgagni hernia. So very commonly given, they have asked a simple question. Most common type of congenital diaphragmatic hernia is left posterolateral, called as Bogdalak. So they have given an image of MRCP showing you choledochal cyst. So this is what I heard from the students. They are telling there is a dilated bile duct like this, fusiform dilated bile duct like this, type 1 choledochal cyst. This is from Todani classification. You can open and see this picture. Very classical explanation is there in Bailey and Love Todani classification. Type of fundoplication we have discussed multiple times. So these are all, I think, mostly evening questions. Type of fundoplication. If it is given 360-degree wrap like this, so there are many types of fundoplication. If the wrap comes 360-degree, it is Nissen. If it comes posteriorly and 360-degree, it is Nissen. If it comes posteriorly and only 180-degree, what is it? 180 to 270 degrees is Taupe. Okay, Taupe. So unlikely complication of ileostomy. Can some of you recall this answer? Unlikely complication of ileostomy, because I could not get the choices. Unlikely complication of ileostomy. So the most common complication of ileostomy is ileostomy induced skin excoriation. That is the most common complication. Surrounding skin excoriation is a common complication. Skin damage and skin excoriation is a common complication. Ileostomy flux fluid electrolyte loss is a common complication. Parastomal hernia is a complication. Ileostomy necrosis, ileostomy retraction, all these are common complications. I don't know what was the choice, but ileostomy, the least common, if at all you want to put, means you can put ileostomy prolapse. Ileostomy prolapse is one of the least common complications. Prolapse of ileostomy compared to colostomy is very less. Ileostomy prolapse is less common complication. So ulcer picture of red clear margin, lower calf ulcer area. So most of the ulcers you can find out what is the ulcer from the location itself. If the ulcer is seen on the medial malleolus, it is a varicose ulcer. Please don't forget, it is a varicose ulcer. If it is seen on the sole of the foot, it is neuropathic ulcer. If you see an ulcer on the dorsum of the foot, it is arterial ulcer. There is no confusion in this. So please remember, medial malleolus, varicose ulcer, neuropathic ulcer on the undersurface, dorsum, it is arterial ulcer. Okay, that's a simple question. So image of subdural hemorrhage was given. It is a concavo-convex image. Garby classification of water lily, chewing tobacco, ulceroproliferative lesion. If you see an ulceroproliferative lesion like this, we have to take a biopsy like this. Okay, wedge biopsy from the edge of the ulcer, deep biopsy, including normal skin. Deep biopsy with normal mucosa, like that question has come. So it includes normal skin also, please remember. So I heard some images, I would have to recollect them from the internet. Recurrent mucus cyst can happen in the lips. Okay, recurrent mucus retention cyst. And congenital inguinal hernia surgery was going on. They have pointed one image of congenital hernia surgery. The only image they can point out here is inferior epigastric artery. So inferior epigastric artery will be seen running like this, and this is inferior epigastric artery, means you can see the sac coming laterally like this. So lateral to inferior epigastric artery. So if at all image is asked, they can only ask inferior epigastric artery image as intra-op image. Pseudomembranous colitis images was asked. Pseudomembranous colitis will have membranes. White membranes can be seen on the picture. And I heard 12 years old boy with a pain in the left scrotal region, and image was given. So that image probably looks like a torsion of appendices of Morgagni appendage is seen on the top of the testis, that is twisted and looks black in color. So testicular appendage with torsion will be the correct answer of that image shown in that picture. So left solitary nodule, what is the next appropriate test? We should first do the thyroid profile, then only we have to proceed for other investigation. So what will you do next means first you should do thyroid profile. Umbilical swelling with the discharge. I heard this is a vitalointestinal duct. So bed sore classification, left pneumothorax with absent breath sounds. With absent breath sounds. All these are common questions. So management of Stanford B aneurysm. So Stanford B, Stanford A is ascending aorta involved aneurysm. B is descending aorta aneurysm. So any aneurysm in the descending aorta, we can go for resection of this aneurysm and we can use a Dacron grafting. So we can use Dacron grafting. So oral fluid with the electrolyte images was asked in the exam. So I hope you know, contains potassium, everything based on that values, we can answer this question. So many other questions, we are still collecting the questions. But if you have any doubts, you can always post in this chat. I will be watching for the chat and I will be replying in the chat box itself. So follow us on DocTutorials channel. We'll have more discussion. Detailed discussion will be done in near short period. Okay, detailed NEET PG surgery questions. Both session 1, session 2, I will do a detailed discussion soon. So you can post your queries or doubts if you have in my Telegram group, Surgery Sixer. I will be answering your queries in Telegram group, Surgery Sixer, and follow my Instagram page on Surgery Sixer, where you can see hundreds of clinical scenarios already, which is discussed in the exam being asked. So please don't forget to follow these channels. And any more doubts or queries you have, you can post it so that I can classify it. So thank you, Hari, for your active participation, Dr. Santosh, Salman. So we'll see you all soon in another session because you'll be in a post-exam mode. Enjoy the exam mode, post-exam mode. We'll see you soon in another session. Okay. Thank you. So you can stop the session.
Yes.
Yeah, thank you. You can stop streaming.